Welcome to Unit 2. This is the first of the chapters devoted to clinical disorders. So I caution you to take with a grain of salt any concerns you may have that you may have a particular disorder. There is a phenomenon called medical student syndrome, which are signs and symptoms which a student believes he or she has while learning about a particular disease in medical school. These symptoms appear to be due to studying a disorder intensely. Now, this syndrome is probably also the result of the anxiety and pressures of being in med school. Psychology students can also fall prey to this sort of problem and a tendency to diagnose the people around them, especially family members, which I'm sure is a real treat for everybody involved. So just relax as we have a look at various anxiety disorders and their symptoms. Anxiety disorders are the most common of the emotional disorders, and they come in many forms and have many symptoms. Now, anxiety disorders differ from normal feelings of nervousness, which we all have. Untreated anxiety disorders can push people into avoiding situations that trigger or worsen their symptoms. People with anxiety disorders are likely to suffer from depression as well. And they may also abuse alcohol and other drugs in an effort to gain relief from their symptoms. Job performance, schoolwork, and personal relationships can also suffer. The central defining feature of anxiety disorders is the experience of a chronic and intense feeling of anxiety, the sense of dread about what might happen to you in the future. This anxiety causes people to have great difficulty functioning on a day-to-day basis. People diagnosed with anxiety disorders experience fear, which is the emotional response to a perceived or real imminent threat. The DSM-5 provides clarification, at least in a clinical sense, about what we mean when we use the words fear versus anxiety. Fear is the emotional aspect. Anxiety, on the other hand, is the cognitive component, which is then accompanied by physiological and emotional reactions. People cope with fear and anxiety in various ways. Sometimes the level of fear or anxiety is reduced by pervasive avoidance behaviors. Now, they are pervasive because they infiltrate important areas of functioning. For example, in social anxiety disorder, individuals may avoid or seriously minimize contact with other people. At home, they may not answer the door. At work, they may miss or skip meetings or keep their office door closed. These types of situations that are feared or avoided and the cognitive aspects associated with them help the clinician to differentiate among the anxiety disorders. For example, in specific phobias, the fear is focused on an object or a certain situation, perhaps spiders or riding in an elevator. In generalized anxiety disorder, the fear and anxiety are free-floating, and they cut across various areas of life. Panic attacks are a symptom and a prominent feature of anxiety disorders. Now, as a symptom, panic attacks may be seen in other mental disorders. I just want to clarify here that panic attacks do not appear in all anxiety disorders, and there are individual differences. People with anxiety disorders have difficulty engaging in adaptive behaviors to manage the fear. Think of a time you felt anxious or fearful, the first day of college or the first day on a new job. The chances are you responded in an adaptive fashion. That is, you handled the perceived threat or new situation through an appropriate response. You went to school or work and made an effort to meet new people. Adaptive fear responses subside when the threat or perceived threat is ended. Maladaptive anxiety persists after the threat passes and can even lead to anticipatory anxiety about the future. Other people in the situations I just mentioned might have had unrealistic fears, so that they responded in a way that was maladaptive. They didn't go to class, or they stopped going to work. With maladaptive anxiety, people behave in ways that lead to impairment. In this lecture, we'll take a look at phobias, social anxiety disorder, agoraphobia, panic disorder, generalized anxiety disorder, obsessive-compulsive, and related disorders, and we'll look at etiology and treatments for anxiety disorders. The causes of anxiety disorders are currently unknown, although research has provided several clues. Areas of the brain that control fear responses may have a role in some anxiety disorders. Anxiety disorders can run in families, suggesting that a combination of genes and environmental stresses can produce these disorders. The role of brain chemistry is also being investigated. And oh, by the way, that's a picture of one of my former girlfriends. I hope she's doing okay. It is best to use a multipath perspective to understand anxiety disorders. A single etiological model doesn't adequately explain the individual differences that we see in symptoms. Remember that the dimensions interact with each other and combine in different ways to result in a specific anxiety disorder. The importance and influence of each dimension vary from individual to individual. As with all mental disorders, the biological dimension shouldn't be overlooked. Some medical conditions may be confused with anxiety disorders. Diabetes, for example, has been linked to some symptoms of anxiety. Also, just having a medical diagnosis may be psychologically stressful and anxiety producing. Some other medical causes include hyperthyroidism and cardiac arrhythmias. Some asthma medications may induce symptoms of anxiety, as well as some stimulants that may have been prescribed. Withdrawal from alcohol also needs to be considered. The withdrawal syndrome from addictive drugs, including alcohol, is the opposite of the drug's effects. Alcohol is a depressant, so the withdrawal syndrome would be characterized by anxiety. To understand the biological dimension, it's also necessary to understand the fear circuitry in the brain. The amygdala is the part of the brain that stores our emotional memories, especially those associated with danger. When we encounter a situation that is potentially threatening or associated with a threatening event from the past, the reaction activates two separate neural circuits, the HPA axis and the amygdala's connections to the hippocampus and prefrontal cortex. The HPA axis is activated quickly and automatically. This is our fight or flight response. The fight or flight response is responsible for physiological changes that occur when there is an actual or perceived threat. With anxiety disorders, it is in overdrive because it's activated too often. Now, when the HPA axis is dysregulated, as in many anxiety disorders, the fight or flight system doesn't turn off. The secondary fear circuit is slower, but it involves higher level processing, which can shut off the HPA axis if it determines that no threat really exists. If the person can engage in effective reappraisal of the situation, then anxiety would be reduced and an adaptive response could occur. Phobias are sometimes due to associations created by classical conditioning. Childhood fears can be triggered in adults simply by sounds, smells, and even words that bring up memories through the amygdala. The psychological dimension can give us insight as well into the development of anxiety disorders. There is a connection between the mind and the body, and someone's psychological characteristics can interact with biological factors and predispositions. Let's say someone was born with a highly sensitive fight or flight system, or with anxiety sensitivity, which is a tendency to interpret physiological changes in the body as signs of danger. This can leave them vulnerable to developing anxiety. Perhaps someone has a tendency to interpret events negatively and has difficulty seeing the bright side. It's as if they have a mental filter that only lets negativity get through, so they only see how things might turn out badly. Consequently, the future is a threatening place. Through the skill of reappraisal, which can be learned and developed in treatment, they can realize there are alternative perspectives and see the silver linings in even the darkest clouds. Being able to reappraise or reframe in a more positive way can reduce anxiety. And let's not forget the social and sociocultural dimensions. We live in a fast-paced society which places a lot of demands on our time. In fact, a recent survey by the American Psychological Association found that 70% of Americans report their levels of stress are unhealthy. Daily environmental stress can produce anxiety, and people with biological or psychological vulnerabilities are most likely to be affected. Some environmental factors to consider are poverty, traumatic events, adverse working conditions, limited social support, and acculturation. And culture can influence how anxiety is expressed. Some cultures express more somatic or bodily symptoms in anxiety, and clinicians must carefully assess and interpret symptoms of anxiety. A culture may have its own set of rules for talking about emotional experiences. Some cultures see mental health problems as social problems. Individuals in collectivistic cultures may hide or minimize their emotional experiences with social anxiety and express them as more socially acceptable somatic complaints to prevent embarrassment. As you study this chapter, pay attention to how the four dimensions of the multipath model may contribute to our understanding of the development of these disorders. Now let's start looking at the specific diagnoses, starting with phobias. They're characterized by strong, persistent, unwarranted fears of a specific object or situation. There's extreme anxiety or panic expressed when the phobic stimulus is encountered. And most adults recognize the fear is excessive, but children may not. Phobias are the most common mental disorder in the United States, and the text lists three categories of phobias: social anxiety disorder, specific phobias, and agoraphobia. The characteristic of social anxiety disorder is marked or intense fear or anxiety of social situations in which the individual may be scrutinized by others. There is an intense fear of doing something embarrassing or humiliating in the presence of others. Some people only experience symptoms when they are in a performance situation, but symptoms can occur in ordinary social settings, and this is much more than just shyness. Now, if the fear is restricted to public speaking, the DSM-5 provides a specifier, performance only, to be used. Essentially, the anxiety is centered on a desire to avoid humiliation and embarrassment. For some, even the simple act of drinking water or eating in public can be embarrassing. The fear or anxiety is out of proportion to the actual threat posed by the social situation. The fear and avoidance are persistent, and they last for 6 months or more. Often, social anxiety disorder is comorbid with major depressive disorder and substance use disorders, as individuals may try to self-medicate. Women are twice as likely as men to have social anxiety disorder, and this condition can be chronic and disabling. A specific phobia is extreme fear of a specific object or situation. Exposure to the stimulus nearly always produces intense anxiety or a panic attack. This object or situation is actively avoided or endured with intense fear or anxiety. The avoidance reinforces the fear, and it is persistent, lasting for 6 months or more. It's common for individuals to have multiple specific phobias. According to the DSM-5, 75% fear more than one object or situation. Although the prevalence is low in older populations, it is one of the more common disorders in later life and tends to be related to concerns over medical conditions. People with specific phobias are up to 60% more likely to attempt suicide than individuals without the diagnosis, but this may be due to comorbidity with other disorders. Treatment from a biological perspective focuses on symptom management. Consequently, anti-anxiety medications are prescribed. Interestingly, research has shown that different phobias show different patterns of brain activation. The primary types are of living creatures such as dogs, cats, elephants, insects, and spiders. Environmental conditions such as heights, storms, or water. Blood injection or injury, for example, needles or invasive medical procedures. And situational factors such as airplanes or flying or being in an elevator. Some other situations are listed and possible factors for specific phobias in the DSM-5, such as loud noises or costumed characters, such as clowns. In the third category of phobias is agoraphobia. Agoraphobia comes from the Greek word meaning fear of the marketplace. There is intense fear of at least two of the following: being outside of the home alone, traveling via public transportation, being in open spaces, being in stores or theaters, or standing in line or being in a crowd. These situations are feared because escape or help may not be readily available. There are concerns over the possibility of fainting or losing control over bodily functions. Or for some, the fear involves concerns over the possibility of having a panic attack. About a third to a half of people diagnosed with panic disorder develop agoraphobia. People with agoraphobia reach the point where they never leave home. They're not afraid of situations themselves, like in the specific phobias, but they fear they can't get help or escape if they have panic-like symptoms. Some cognitive behavioral treatments for phobias include the following. One is exposure therapy, which usually is a gradual introduction to the feared object or situation. Now, the textbook does not give a clear indication of flooding therapy, where people are placed in situations at their worst. For example, someone afraid of flying would be placed on a plane to extinguish the response under the principles of classical conditioning. Usually, though, a gradual introduction to the feared stimulus is preferred by clients and involves imagery first. Now, there's a need for truly graphic imagery, and there are ethical considerations for both client and therapist. For a person with a spider phobia, the following script might be used. Close your eyes and see a hairy spider at your feet. See it crawl around your feet and ankles. Make yourself pick it up and put it in your lap. You don't want to do it, but you make yourself pick it up. Look at the spider in your lap. Feel it moving around. Keep your hand on the spider and prevent it from walking away. Feel the texture of its hairy surface as it moves around in your hand. Bring the spider up closer to your face. Force yourself to look at it. The intense anxiety that the client with spider phobia feels is exactly what must occur. But this therapy is done only after the client is informed of what will happen and the reasons for it. Also, the therapist, who probably does not enjoy the thought of creating terror in a client, must believe in the therapy and stick it out despite the client's anxiety. If the therapist starts to use exposure therapy, there's no turning back. Stopping the presentation of fear-inducing scenes before there has been an extinction of the anxious responses will reinforce avoidance. Another technique is systematic desensitization, which involves a gradual, slower, more comfortable process of exposure while the client is in a relaxed state. This way, the client learns to relax and pairs this calm response with the stimulus. Cognitive restructuring involves identifying and changing irrational or anxiety-producing thoughts that are associated with the phobia. And finally, modeling therapy is viewing another person's successful interactions with the feared object or stimulus. In this way, clients learn to no longer fear the phobic stimulus through observational learning. Another diagnosable anxiety disorder is panic disorder, which involves recurrent unexpected panic attacks. This is combined with apprehension about having another attack or behavioral changes designed to avoid having another attack. The reactions are present for 1 month or more. People with panic disorder experience periods of intense physical discomfort known as panic attacks. During a panic attack, people may feel like they're going crazy, losing control, or that they're going to die. There's a sense of impending doom. Now, having an occasional panic attack is not enough for a diagnosis. They have to happen more than once. And there has to be evidence of fear of having another attack and maladaptive behaviors to avoid another attack. It is this fear or avoidance that distinguishes panic disorders from other disorders that may involve panic attacks. Some of the symptoms of panic attacks are palpitations, sweating, shortness of breath, feeling like you're choking, chest pain or discomfort, feeling dizzy or feeling nauseous. The 12-month prevalence rate for panic disorder in the U.S. is 2.7%, and it's twice as common in women as in men. Now, treatment can involve imipramine, which is a tricyclic, one of the older antidepressants, which can reduce panic attacks in the majority of cases. SSRIs are also effective. Clients are taught relaxation techniques and breathing exercises, which give a sense of control and help clients to ride out the wave, if you will, and learn that the attack will pass and that they won't die. These relaxation techniques help to calm the HPA circuit and stop the fight or flight response. Cognitive behavioral treatments teach clients to recognize catastrophic thoughts and reframe to reinterpret their bodily sensations. People diagnosed with panic disorder tend to interpret bodily sensations in a very negative way. Cognitive behavioral therapy is very effective in treating panic disorder as it increases self-efficacy and a sense of control over one's body. It teaches coping statements to address catastrophic thoughts like, I am dying, I'm losing control, I am going crazy, whenever there's a perception of unpleasant bodily sensations. This way, clients can stop the negative cycle, which is shown here, which can make panic attacks worse. Some people are anxious all the time, in most situations. People diagnosed with generalized anxiety disorder worry about many things in their lives. People with GAD are also tired most of the time. Persistent high levels of anxiety and excessive hard-to-control worry over life circumstances characterize GAD. The DSM-5 diagnostic criteria include that symptoms must be present on the majority of days for 6 months, and these symptoms cause significant impairment in life activities. This disorder tends to develop gradually and often begins in childhood or adolescence. Many people with GAD report they have felt anxious and nervous most of their lives. This excessive worrying makes it difficult for them to do things quickly and efficiently. These individuals are focused on potential threats, and you may hear something from them like this: it's always best to expect the worst. They believe worrying can help them avoid bad events, but this worrying keeps them from engaging in active problem solving. Psychologists have shown that people with GAD focus on potential threats. And they've done this through the use of the Stroop color naming task. In this task, words are flashed on a computer screen for a brief period of time, and the person is asked to name the color of the word. People with generalized anxiety disorder are slower to name the color of the words with threatening content compared to neutral words, presumably because they are attending to the content of the threatening words. And here's what it looks like. A card would be flashed, and the correct answer would be red. Another card would be flashed, and of course the correct answer here is green. What psychologists found was it took longer for those diagnosed with GAD to name the color of the cards with words like disease compared to neutrally worded cards. Another category of anxiety disorders includes the obsessive-compulsive and related disorders. In obsessive-compulsive disorder, there are consistent anxiety-producing thoughts or images, the obsessions. Now, these thoughts are intrusive, unwanted, and distressing. There's also an overwhelming need to engage in activities or mental acts to counteract anxiety or prevent the occurrence of some dreaded event. These are the compulsions, the actions. Now, compulsions do not always occur with obsessions. In obsessive-compulsive disorder, individuals experience either obsessions or compulsions to such an extent that they find it difficult to conduct their daily activities. The action, the compulsion, such as excessive hand washing, is designed to neutralize the obsession. The obsessions and compulsions are time-consuming, and they take more than an hour per day. I had a client who was constantly late for work because on the morning drive he would have intrusive thoughts that he had hit a pedestrian on the road, and he would drive back to check over and over and over again. Eventually he lost his job because he was always late for work, and this met the dysfunction criteria for abnormal behavior. From a sociocultural perspective, the focus of obsessive thoughts seems to be similar across cultures, most commonly consisting of dirt and contamination concerns. The prevalence rate doesn't seem to vary greatly across cultures either. Some studies have shown higher rates in women, while others have not. Many individuals with OCD experience panic attacks as well. And suicidal thoughts occur at some point for as many as about half of individuals with OCD. Suicide attempts are reported in up to a fourth of individuals diagnosed with OCD, and comorbid depression increases that risk. Biological theories on the etiology of OCD have focused on more activity in a circuit in the brain involving the thalamus, frontal cortex, and basal ganglia. PET scans of people with OCD show more activity in these regions compared to people without OCD. And I've pointed out here the regions of the normal control, and you can see in the lower half of the PET scan how these regions, these three regions, are lit up more in the obsessive-compulsive patient under different conditions. Now, family history studies clearly show OCD runs in families, and twin studies support a substantive genetic component as well in its etiology. The psychological dimension of OCD is also important to consider as well. According to cognitive behavioral theories, what differentiates people with OCD is people with the disorder are unable to turn off intrusive thoughts. Also, these individuals tend to engage in rigid thinking, so they would become more anxious, which makes it harder to dismiss the thoughts. According to cognitive behaviorists, compulsions develop largely through operant conditioning. People discover certain behaviors reduce their anxiety, so the behaviors are negatively reinforced. The aversive stimulus, the distressing thought or anxiety, is relieved temporarily by the compulsion, which then reinforces that compulsive action. In the treatment of OCD, selective serotonin reuptake inhibitors, SSRIs, are the most effective biological treatment. In extreme cases, when no other treatment provides relief, people with OCD may be treated with psychiatric neurosurgery. For example, deep brain stimulation to areas involved in motor control may help relieve symptoms by reducing the activity of the prefrontal cortex, which in turn may reduce the frequency of obsessive-compulsive thoughts. Cognitive behavioral clinicians may use thought stopping to help clients reduce their obsessional thinking. Thought stopping can involve shouting stop loudly to interrupt that negative cycle of thinking. It may also involve visualization of a large stop sign as well. Also, clients may be exposed to anxiety-provoking situations and then instructed not to perform the compulsions. The idea is that clients confront their obsessional thoughts for so long that they will lose their meaning, and this will also extinguish the conditioned response. Other types of OCD-related disorders are discussed in the text. Body dysmorphic order is a preoccupation with a perceived physical defect, and the symptoms cause clinically significant distress or impairment in life activities. People with body dysmorphic disorder are preoccupied with the idea that a part of their body is ugly or defective. They may check themselves constantly or constantly seek reassurance from others about how they look. Many will seek cosmetic surgery, and occasionally individuals may perform surgery on themselves. They may believe others take special notice of them and mock them because of how they look. Another disorder is hair pulling disorder, where there is frequent and recurrent hair pulling despite repeated attempts to stop. Skin picking disorder is another diagnosis, and this can be very serious as it results in skin lesions. And finally, hoarding disorder, the inability to discard items regardless of their value. The decision to add hoarding disorder to the DSM-5 has aroused some controversy, but there have been media reports describing people who have died because of being trapped in their own hoard. Obviously, quite a few people hate to throw things out, but to diagnose a mental disorder, a person must be functionally disabled due to hoarding. And hoarding is more prevalent in older adults, and this can also involve the hoarding of animals. In concluding this lecture, I first want to say I hope you've resisted the temptation to diagnose yourself or the people you know. I'm sure they'll appreciate it. Secondly, as you read and study this chapter, you'll become aware that cognitive behavioral therapies are considered the most effective in treating anxiety and OCD. Many who show improvement do relapse, so we need to continue to explore etiology and develop new treatment approaches. New medications continue to be developed because a problem with benzodiazepines is they are potentially addictive, and relapse in anxiety disorders tends to occur when they are stopped. Some new treatment approaches include specialized therapy programs targeting specific disorders. And these include motivational enhancement therapy to improve compliance with treatment and mindfulness training to improve anxiety tolerance. Now, these approaches may be integrated with cognitive behavioral therapy. Since people are often diagnosed with more than one disorder, some developments are to find treatment protocols that can be used across disorders. And technology in the form of computer programs and online counseling can improve access to treatment and help with relapse prevention.